the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice. Welcome back, listeners. Today I'm going to do a review of a prior presentation we had in Phoenix in 2019 where Dr. Dehghan discusses elbow arthritis and arthroplasty. So there are several x-ray and intraoperative images that accompany this talk, and for the optimal experience, please listen to the podcast and follow along on our YouTube channel, PAs and Orthopedic Surgery. Okay. So to begin with, Dr. Dehghan discusses the reasons why someone might get elbow arthritis, including osteoarthritis, rheumatoid arthritis, and post-traumatic arthritis.
So types of arthritis, same as any other arthritis. You have your osteo, your rheumatoid, or inflammatory. And in the elbow, really post-traumatic arthritis. So if you fall and have a distal humeral fracture or an olecranon fracture, you have it fixed and it falls apart, or it's not fixed properly, you have a malunion, and you go on to develop degenerative change and post-traumatic arthritis. So we really have three different types of patient populations who get these conditions, and we'll go through that.
She then describes non-operative versus operative management of elbow arthritis.
So the management of elbow arthritis, like any other arthritis, always non-operative first, so that's anti-inflammatories. For rheumatoid, it would be your rheumatoid medication, activity modification, but really when they can't tolerate those, it would be surgery. And for elbow, debridement, whether open or arthroscopic, actually has really good outcomes, as opposed to, let's say, knee or hip. Elbow patients do much better with the debridement. And then you have your elbow arthroplasty. But there's also kind of weird things we can do, like interposition arthroplasty, which basically you take a piece of tissue and wedge it in between the joint just to give some kind of cushion, so when your elbow's moving, it's not grinding so much. And an elbow fusion is really the last resort for, let's say, someone really young and active, labor type of person who you don't want to do an arthroplasty on. Arthroplasty is really delicate in the elbow. It's not like the hip or knee. It doesn't, the longevity isn't as much. An elbow fusion gives them a nice stable elbow that they can lift and do all kinds of things, but obviously it's awkward because it doesn't move. So, but I think we'll kind of go through the first two as opposed to the last two, because those are, like I said, rarely done.
Next, she reviews the common history and incidence of osteoarthritis of the elbow and discusses some x-ray presentations.
Osteoarthritis in the elbow, really it's your classic osteoarthritis with lots of osteophytes and extra bone being formed. Usually middle-aged men, especially laborers, this is really classic in. And the pain they have isn't necessarily from the joint being destroyed. It's really from impingement that they have their symptoms in. So when they extend their elbow, the tip of the olecranon kind of bangs against the distal humerus and they have pain and they can't straighten. And then when they flex, the tip of the coronoid bangs in against the distal humerus and they have pain. So they lose their motion because of the osteophytes. And because they lose their motion and they get stiff, they can also get ulnar nerve symptoms. Especially your ulnar nerve, it's in a tight canal. So when there's all this extra bone being formed, it squeezes the nerve and they can have paresthesias. So this is kind of your classic osteoarthritis of the elbow. And there's a pointer, there you go. So you can see there's all this loose bodies around. The coronoid is really peaked, the tip of the olecranon. And this is more of a severe pattern, but this is different than rheumatoid arthritis of the elbow, and we'll look at that next. So this is more of a mild condition. You can see there's these loose bodies here, the coronoid is really peaked, and the tip of the olecranon, and you can see it better on that CT scan. So you can imagine why these patients would have impingement. So when they extend the elbow, you can see that tip of the olecranon just keeps banging right into that distal humerus, and it causes them pain. And same when they flex, this coronoid tip, which shouldn't be so long and peaked, it should really end right about here. But all that's extra bone formation, so this keeps banging up against the distal humerus and causes pain. And what are these things? Anyone? Loose bodies. They're pearls in the elbow. It's really exciting when you go fish those out. So they classically have a lot of loose bodies with osteoarthritis.
So what is the surgical treatment for osteoarthritis of the elbow?
The treatment for this condition, especially in young, active, let's say middle-aged laborer, because that's classically who gets these, you don't want to do an elbow replacement in this type of patient, because like I said, elbow replacement's really a delicate, let's say for older ladies who drive to church, once a week kind of thing. So limited use, low demand, that's the type of patient that does well with an elbow replacement, not a 40-year-old laborer, active type of person. They'll just thrash it apart. So things we can do for this condition is really debridement is really good for this type of arthritis, especially if it's mild in the sense that your ulnohumeral joint is well preserved. And you can see here the ulnohumeral joint isn't actually terrible. If you just take away these loose bodies and the beaking at the back and the front, the patient's going to really improve a lot in terms of their function. The impingement goes away, and that grinding and catching from the loose bodies goes away. So really in that type of patient, the transhumeral debridement, or you can do it arthroscopically if it's more mild, that's really the mainstay of treatment. And total elbow arthroplasty is reserved for really end-stage arthritis in the right patient. So again, not a young demand type of person, an older, lower demand.
Dr. Dehghan then describes an example of an open debridement which is accompanied by pre- and post-operative images you can see on our YouTube channel.
So we'll talk about transhumeral debridement. So this is your radiographs, and you can see the before with all these extra bones and the after. So basically you go in, create a big hole right here in your olecranon fossa, take away the tip of the olecranon, take out all the loose bodies, and then through the hole you've created, you can flex the elbow and you can see the tip of the coronoid looking at you, and you can resect the tip of the coronoids as well. And you can take away all the capsule. You can do really a lot through a small incision, let's say that much, so maybe 4 centimeters or so. Small incision at the back, you can really do a lot of work. And that's how it looks on the lateral. So you can see the tip of the olecranon has been resected, create that big hole right here that we saw in the other view. So that's the big hole. Go in, flex the elbow, and take the tip of the coronoid over here. Take away all these loose bodies. You can see how much happier this elbow is going to be when you take away that impingement that they have. And again, the ulnohumeral joint has to be reasonably preserved, which it is usually in these types of patients. So this is just a clinical picture. Again, the tip of the olecranon has been resected. You create this big giant hole. And it looks very aggressive, but if you actually look at your distal humerus, the olecranon fossa, it's really almost paper thin in a normal elbow. So you're not supposed to have so much bone there, except if you have arthritis and all this extra bone formation. So all the loose bodies are gone. That's the anterior aspect of the elbow. You're looking through the anterior. This is the back, the posterior. So through this hole, you can find the tip of the coronoid, resect it, take away all the loose bodies from the front as well, which is really fun when you fish out all these pearls. Gets very exciting. And that's really the main part of the transhumeral debridement. And you can do this arthroscopically as well. If it's more mild disease, or if really their symptoms are from catching of these loose bodies, you can go in and fish out the loose bodies. And that's also another option.
Next up, she compares and contrasts rheumatoid arthritis, which is different clinically from osteoarthritis.
So rheumatoid arthritis. Now, rheumatoid arthritis used to be a lot more common, but really in the last decade or so, the numbers have really gone down, and that's because of the new medications we have for rheumatoid arthritis. So the biologics, anti-TNF medication, and really a lot of rheumatoids have such good medical management that rates of elbow arthritis is going down. But a good chunk of patients who have rheumatoid arthritis do get elbow arthritis as well. So the pathology is different, as you know, in rheumatoid as well, as opposed to osteo. So osteo, whereas there's all this extra bone being formed and there's this hypertrophic action going on, rheumatoid's almost the opposite. Things are getting resorbed as opposed to being formed. So there's a lot of synovitis. Your ligaments are getting lax, things are getting chewed up, elbow's kind of unstable because of that, and there's a lot of erosive changes that are going on.
She then shows an example of a patient with rheumatoid arthritis of the elbow and reviews total elbow arthroplasty as the treatment of choice for patients with rheumatoid arthritis and degenerative changes of the elbow.
So this is a classic X-ray of an elbow arthritis. You can see it's different than that, than the osteoarthritis with all the osteophytes. So the ulnohumeral joint is gone. That's basically bone on bone. But the elbow's kind of sublocks. There's no radial head. Like, what happened to the radial head? It just melted away. And you can see even here, there's all this bone loss. Almost looks like a metastatic or lytic picture that Dr. Dehghan was showing. So bone is kind of getting destroyed and chewed up. So different type of pathology. So in these patients, really the mainstay of treatment after non-operative management is elbow arthroplasty. So rheumatoid with terrible elbow, total elbow arthroplasty. There's really nothing to debride because they're missing bone as opposed to building too much bone. And the problem is elbow instability, not stiffness and impingement. And most of these patients are lower demand. And if you think of the classic rheumatoid, and usually they're women, so the classic rheumatoid older lady, they have multiple other joints involved. They have all these deformities of their hands, wrists. They don't really do much. So if you give them a good total elbow arthroplasty, it's enough for them to kind of do their activities of daily living, function, do some work, and that's a good surgery for them. So this is a total elbow arthroplasty. So it's a linked components. So that's how it looks at the front and at the back. How many people have seen total elbows? Okay, so it's not, it's not like hip and knee where you bang out like 10 total knees in 2 rooms every day. Much rare because the indications are rare, the disease is more rare, so less prevalence, and it's not as robust of a surgery, so your patient population in terms of who you can select for the surgery is less common as well. And the main problem with this is there's significant restrictions in terms of activity. So we usually say, 5-pound maximum lifting. And that's because this is not as sturdy, like I said, as a total hip where you can just stomp on it. If you do this in a young, active person, they'll thrash it apart and it's not gonna last. So it has to be used very gingerly. So I usually tell patients, it's like having a classic car. You can drive it to, the classic car show once a week and, wax it or do whatever you do, take care of it. It's not your go-to car where you drive back and forth to Tucson every day, okay? So you have to take care of it. And, what you tell patients to do and what they actually end up doing is, not always the same thing. So we always tell them that 5-pound weight restriction, and that's really repetitive lifting. So it's not like if they lift 6 pounds, their arm's gonna fall off, but you really don't want them to do repetitive lifting with this type of prosthesis. And for some patients that means no golf or no tennis. So again, if golf or tennis is a huge part of your life and you want to take that risk, within reason, but again, heavy repetitive things. So if you have an active elderly person who plays tennis every day, probably may not be a good surgery for them. And again, not a lot of bone in the elbow. So the ulna is really small. Distal, humerus is smaller than a femur or a tibia. Ulna is even much smaller. So if this fails and you need to do a redo, you're looking at a lot of bone loss, and the revision is more difficult. So that's one of the concerns. So like I said, subgroups, this is really good surgery for elderly females, rheumatoid, it's great. Young patients or post-traumatic arthritis, which we haven't talked about yet, really high complication rates.
Okay, listeners, that's all the time we have for today, but please stay tuned to next week for a discussion of elbow arthritis and management by Dr. Dehghan. The discussion and images are taken from a video on the free resources page of the PAOS Learning Center, Ortho in the West, Phoenix 2019. We also welcome you to visit our website, paos.org, where members can download virtual conference content and get Category 1 CME. Also, if you're a non-member and you're interested in our CME content, please visit the aapa.org Learning Central for the PAOS virtual content.